This is coronavirus brief update number 2 for Granville County EMS, recorded on April 3rd, 2020. And if you haven't had a chance to listen to the brief update number 1, please do so. I included a link for that in the notes to this video. And as we stated both at this month's coronavirus CME as well as in the previous update, the point of these updates is to keep you in the loop, to make sure that you have, to the best of our ability, the most up-to-date data in terms of treating your patients, policies and procedures, and of course, keeping yourselves safe. We're also going to use these updates to preview what might be coming down the road so that any changes in policies or procedures in the future aren't blindsiding you. At least hopefully we will be able to give you a heads up as to where things might be headed. So as we did with the previous update, I like to start with the stats because, again, I think as medical providers, you are leaders in your community. People will look up to you, and the better information that I can give you, the better information that you can give them. So just to get a sense of where things lie, as of today, we have a little over 2,000 cases. Now, the last update we did, which was a bit over a week ago, we had 500 at that time. At that time, we also had one death. You can see there have now been 19 in the state confirmed due to coronavirus. We continue to test, although our testing is not as prolific as some other states. And you can see a fair number of patients hospitalized. So that's where things stand. And I want to start by reminding you what we discussed in the first update is that we really have established community spread. So what this means is that the overwhelming majority of cases of coronavirus in North Carolina are coming from within North Carolina. And something that's very important that's emerged in even really just the last week is the realization of just how many asymptomatic people there are who are shedding virus. And so in some statistical models, it may be as much as half of the cases of coronavirus that people are catching, they are catching from asymptomatic people who either just don't have symptoms yet, or quite a few of whom may never develop symptoms. So this is a bit of a problem. It makes it much harder to trace cases, to quarantine people. If people are showing no signs of illness, then it's really hard to know who is spreading virus. And so that's a very important point to keep in mind. At this point, we have to assume that every person is capable of shedding coronavirus, no matter how well they are, no matter how they look, no matter how they feel. And so you should keep that in mind, not just while you're at work, but in your day-to-day life as well. So I'm getting a lot of questions about how do we treat coronavirus patients? How do we treat them differently? And, I understand where this is coming from. If you go on CNN or Yahoo, you'll see articles about how Motrin might be bad for coronavirus. And some people have taken that a step further and said, well, maybe we shouldn't be giving any NSAIDs, any antipyretics. You'll also see people talking about how the CDC has guidelines that says nebulizers and steroids should not routinely be given to coronavirus patients. And some people have wrongly interpreted that to mean we shouldn't be giving those to anyone with suspected coronavirus. Although not as pertinent to EMS, you'll hear talk about how ACE inhibitors and related blood pressure medications like ARBs may be detrimental, and some people are wondering, should I stop these meds? You'll hear ICU doctors talk about how they run patients dry, meaning they keep them on the dehydrated side to avoid some of the fluid overload that we see in the lung injury associated with coronavirus. And so some EMS providers have asked me, should we withhold fluids? So the short answer to all these questions is really no. And by no, I mean we just should not be changing our care at all. There's not enough evidence for any of these things at this point in time to change what we do. So what I'm saying in a nutshell is if you have a patient in front of you who has confirmed or suspected coronavirus, you should be doing the exact same treatment for that patient that you would have done for that person 6 months ago based on their signs, their symptoms, their exam, their history. EMS algorithms are very much about treating what you see. You treat what's in front of you and you provide symptomatic care. So For example, if a patient is hypoxic or complaining of shortness of breath, give them oxygen, right? See if the numbers come up, see if they feel better. If someone's wheezing on your exam, give them nebulizers. If they respond to those nebulizers, consider steroids and other parts of that algorithm. If someone's tacky and febrile, yes, NSAIDs, fluids. But if you listen to their lung exam and they're fluid overloaded, obviously withhold fluids, consider other interventions, oxygen therapy, BiPAP. My point is, we still follow our algorithms. The fact that the person in front of us may or may not be COVID positive changes nothing in terms of our treatment. What we should be doing differently, of course, is putting a mask on those patients. On anyone who will tolerate a mask, we should be putting masks on our patients immediately, as soon as we're at bedside. And of course, we should be wearing PPE. That's the difference, but not the treatment that we should be giving. So another question that's come up is, questions around exposures, illness, returning to work after illness. So at this point in time, whether or not you've been informed that you have transported a patient with COVID or had a high-risk contact, it's pretty much irrelevant. We have to assume that every patient we're transporting, even when they're perfectly healthy, is potentially shedding virus. And so, statistically speaking, virtually everyone listening to this video has already been exposed. We will continue to be exposed, and therefore, I would say we need to be self-monitoring at all times. Meaning, don't come to work if you develop signs of illness. Fever, cough, shortness of breath. Also, GI symptoms. We're starting to realize that diarrhea is a fairly common complaint early in the illness. Sometimes it's the first complaint. And so if you think you have any signs of illness, you need to be contacting your supervisor, contacting Jonathan, Paula, in infection control, and we need to be working with you to make a decision on whether you can come to work, or if not, how long you need to be out of work. Now, some people have been asking, if I have a positive exposure, if the health department tells me I'm exposed, I transported a patient who tested positive, do I need to be out of work for 14 days? And the answer is no. We are not doing that anymore. We were doing that early in the outbreak because what we were trying to do is prevent the establishment of community spread. And so we were being extremely cautious and saying that if anyone traveled abroad or had a known exposure, that they needed to not come on hospital property. At this point, coronavirus is everywhere. As I said, we've all been exposed already. And so this, taking 14 days off work doesn't really make sense. It's not accomplishing what we want it to at this point in time. What we really need to be doing is monitoring. And so if you've had a known exposure, over the last week or two, if you've been one of the people who has had a known exposure and you've been notified of this, occupational health generally, in most cases, will put you on twice daily health monitoring, checking in with you, asking you to wear a mask at all times while you're at work, even when you're not around patients. This likely will also stop pretty soon. Because we're getting to the point where we're not even doing contact tracing, which means the health department is not even trying to trace positive contacts. So from here on out, we really have to assume all patients are positive. Every patient is high risk. We need to be wearing PPE universally. We need to be self-monitoring continuously. We're all having known exposures. And really what matters is if you become symptomatic. So again, any symptoms, you should not be coming to work, which of course raises the question, when can you come back? And so at Granville, we are using the CDC guidelines. So the CDC guidelines say that if you have any symptoms, at a minimum, you're out for 7 days from the onset of symptoms. At the 7-day mark, you can reevaluate. And if you have not had fever for 3 days, and this is without Tylenol or Motrin or naproxen use, and if your shortness of breath or cough are notably improving, you may return to work. But you have to be 3 days fever-free with notably improving symptoms. So I realize this is a little subjective, and there will be some judgment calls that, Paula in infection control and we will have to make. But, the 7 days, that's objective. It's got to be at least 7 days out. 3 days without fever, that's objective. You need to be measuring and checking. Shortness of breath, also pretty objective. Obviously, you need to be able to do the duties of your job, lifting gurneys, lifting obese patients, moving 40 pounds of gear, defibrillator jump bags around. You have to be able to maneuver around the ambulance. So clearly, you need to be in pretty good shape cardiovascularly in terms of your respiratory status and comfort. Now, cough, this is the tricky one because we know people will have a prolonged cough following illnesses. Some people get a bronchitis. If you have a history of asthma, you may be particularly sensitive and cough for many weeks after a viral illness. So notably improving is a little bit subjective. Again, this is something we will probably have to work together on, involving infection control from the hospital. But regardless, once you do come back, you have to wear a mask at all times until 14 days after the onset of symptoms or all symptoms have resolved. And so for people with a nagging cough, it means you may be wearing a mask for a couple weeks. And I realize that's uncomfortable. So although I don't have a slide for this, there's one other thing I wanted to mention, and this was in the recent update guidance by the North Carolina Health Department. So transporting family members, ideally, we should not be transporting anyone but the patient. I know sometimes we allowed people to ride in the back, to ride up front. Ideally, no, you should not have anyone else in the ambulance. Now, there are, of course, going to be patients where you can't avoid this. Like you're not going to separate a young child from a parent or a caregiver. Some people, some spouses or relations to the patient may not be able to be left at home. These situations occur, but to the extent possible, please try not to transport anyone else in the ambulance. If you have to transport someone else in the ambulance besides the patient, unless there is an incredibly compelling reason, they should be sitting up front. The other thing, and some people have bristled at this, is that they, regardless of whether they're up front or in the back, should not be given PPE. Now, you might be saying to yourself, whoa, why does that make sense? Well, here's the thinking behind that. If this person is so important to the care of the patient, mother of a child, spouse of someone with chronic medical conditions, they have been around that patient, for long periods of time while that patient has been symptomatic. If they're going to get it, they have already got it. They've already had significant exposure time with that patient. So putting a mask on them in the ambulance for 10 minutes to minimize their exposure risk doesn't really make sense in the context of the fact that they've already had long periods of exposure with that patient. We're not going to be changing outcome by doing that. So all you are going to be doing is basically wasting PPE. And given the absolute need to conserve PPE as much as possible, it doesn't really make sense to be giving it to family members who are riding in the ambulance. So I wanted to clarify that because that question has come up on the SC2 protocol. So just to finish here, where are we headed? So, well, obviously in the short term, we're still focusing on surge options. PPE is our primary focus, preserving and extending the use of PPE, trying to keep all of our healthcare providers as safe as possible. And then I have mentioned, North Carolina did suspend the requirement for 2 EMS providers per ambulance. The one provider option has a lot of downside. It is absolutely only as a last resort tactic, but that option does exist. But what I think is really going to matter in the next couple weeks is figuring out who's immune. So one of the things that the models that have just come out over the last week, particularly some out of Stanford, has shown is that there's much higher rates of asymptomatic infection and transmission, which is scary because it means we don't know who is shedding virus. But it also means that far more people than we believe have already been exposed and have already, beat the illness. They did not get sick. They're on the other side of it, which means they probably developed antibodies. And you're going to hear a lot about antibody testing. And for your knowledge, I wanted to clarify what that is. So there's a difference between testing for antibodies and testing for active infection. When you test for antibodies, you're seeing if someone's body has fought the virus and mounted an immune response. You don't create antibodies until you're well within an illness. So antibodies really tell you who had the infection, not who has active infection. To test for active infection, you actually have to test for the presence of the virus. And so what you do is you swab their nose, and what you're actually testing for is the genetic material of the virus. You're testing for bits of virus. So there's a difference between antibody testing and testing for infection. But what we're really hoping for soon is an antibody test. And there have been some antibody tests that seem to perform reasonably well. They have just been fast-tracked by the FDA. They are trialing some of these in Colorado right now. And the reason we want to be able to do this is because it would be pretty wonderful to know who's immune, right? I mean, as a healthcare provider, you certainly would want to know if you're immune, especially if there's a decent chance you've already developed antibodies, because we know those antibodies are likely protective. If this virus is at all like previous coronaviruses or the SARS virus, we know that those antibodies will give you at least some protection, probably a year or two, maybe even longer. But that would mean that those of you who already have antibodies are protected probably now, but also probably well into the next cold and flu season. So being able to figure out who has antibodies, even if they had asymptomatic illness, is key. It would really help us adjust staffing and to sort of plan our resources. And so I think that's where we're headed. I'm hoping that there will be testing widely available by the end of April. But I wanted to put that out there because you're hearing a lot about it in the news, and I wanted you to be clear on what that is. So as always, if you have any questions, please contact me directly, or you can contact me through Alan or Jonathan, and be safe. Thank you.